Well, probably it's a good time to start. So, welcome you all. This is a new webinar of our global series. Uh, Definitely, PrEP uptake is slowly moving forward around the globe, and in some cases, it's being implemented as part of a government decision, while in others, it's actually the initiative of potential users and their communities. And there are also champions among health providers who are playing a key role. I know that this is the case in Spain, where there are active groups promoting, discussing with the governments and regional governments, the national government, and looking for options. Um, and definitely in that country, as well as in other European countries, cost issues represent a barrier at this particular time, because the patent for Truvada is still in place. It's not going to be the case very soon. However, new opportunities may be emerging, as I'm saying, relatively soon. So in today's webinar, the idea is to have Pep Coll, Dr. Pep Coll, and Michael Meulbroek from Barcelona, talking about the situation in Spain. What's happening with access to PrEP in Spain, what the challenges are, and what efforts are being made. Briefly about both of them. Pep is the Clinical Cohorts Coordinator at the HIVACAT Programme, the project for the development of HIV vaccines at the irsiCaixa AIDS Research Institute, and a physician at the HIV Unit at the Universitari Germans Trias y Pujol in Badalona, in the region of in Catalonia, Spain. He collaborates in the recruitment and follow-up of several cohorts, HIV acute infections, controllers, rapid progressors, and he has conducted cohort studies of HIV-uninfected men who have sex with other men, in collaboration with the community-based organization, the Barcelona Checkpoint. He's also working in human papillomavirus. So, concretely in anal cancer among people living with HIV. So, at this point, Dr. Coll is focused on strategies for prevention of HIV, including PrEP and other STIs among MSM at risk in Barcelona, collaborating with Barcelona Checkpoint. Concerning Michael, who will speak after Pep, he's the chair of Proyecto del NEMUS Hispanocida. He was born in Amsterdam and has lived in Barcelona since 1986, where he was diagnosed with HIV. In 1993, he co-founded Project del NEMUS Hispanocida, one of Spain's most important HIV/AIDS community-based organizations. He's also a treatment counselor and educator within InfoTrad, a peer-focused information and education program for people living with HIV. In 1998, he co-founded ATOS, Association for Organ Transplants for people living with HIV. Then his latest project in 2006 has been the implementation of the Barcelona Checkpoint, the community-based center for HIV and STI detection for MSM and community research. Anyway, they are both actively involved in community health and empowerment, and they are providing complementary perspectives on the situation concerning access to PrEP in Spain. This is one of our webinars. We'll have their presentations first for about 30 to 40 minutes, and then we hope to have some time for discussion at the end. For that, we have a chat window in your menu, in your GoToMeeting menu, and you can use it for questions or comments. And finally, this webinar is going to be recorded and uploaded in our YouTube channel and our website later. So anyway, Thanks a lot for being here with us today. Pep and Michael, welcome. And please, the mic is yours.
Yes, good morning, well, good afternoon in Spain. Thank you very much for the invitation. And well, this is the we are going to talk about access to PrEP in Spain and its challenges and ongoing efforts. The agenda for my presentation is this, that I just review a little bit about the background, and we'll see the recommendations in Spain and what's the current situation in Spain, the challenges, and after that, Michael will talk about the community initiatives. So starting with the background, just let me remind that the HIV incidence is very high among MSM. In Europe, it's going up. And in our country, in Catalonia, then the incidence is also high, as you can see in the red line. It seems that this last period, there could be a slight decrease, but anyway, it's quite high, as you can see. Then talking about PrEP, well, we know that the PrEP it's worse. We know the efficacy through different clinical trials. In most of them have shown the efficacy with the reduction of HIV incidence, significant reduction of incidence, except two studies, two trials implemented among women, African women, which was the VOICE and the FemPrEP, where no reduction, no protection was shown. But we know that this was because of lack of adherence. So we can say clearly that the PrEP works if it's taken. You can see the adherence in these different studies are more or less well acceptable, except for the FemPrEP and the VOICE, and that probably would be or clearly is the main cause of this lack of efficacy. Also in Europe have been implemented clinical trials. The most important are the PROUD study in the UK and the IPERGAY study in France, in Canada, but most of the participants were from France, and they show the same reduction in HIV incidence, which was 86%. And in the IPERGAY open label phase, this reduction of incidence was even higher, was 97%. Also, we know that we have more and more information available that PrEP is working in real world. This is a study which was published in 2015 in San Francisco. This is not a clinical trial. The study was implemented among more than 650 MSM at risk of infection in San Francisco with this period, and any new infection was detected. So we know that also in real world, because there were some concerns about the effectiveness of the PrEP, because we hear some saying that it's not the same a clinical trial as the real world, but we know that it works even better. So let's go to the recommendations in our country, in Spain. There is a document which was published, guidelines published in July last year. This document, it's been elaborated by HESIDA. HESIDA is the Grupo Estudio de SIDA, the HIV study group, and there are doctors, infectious disease specialists, internal medicine specialists, and also representatives from the community. And in fact, in this document, in these guidelines, Michael and myself participated on the elaboration of these guidelines. And the recommendation is it's very clear. It's absolutely clear and agreed between all of the authors. Then it's stated that the PrEP should be recommended to all the people who can have a high risk of infection for HIV. And this high risk is defined by being a population with HIV incidence higher than 2% per year. If we look in our epidemiological context, we see that SM and transgender women are within this group. And if we specify the criteria where this population could be at risk, what define this criteria? No, people with sex with more than 2 partners, and in the 6 months, the previous 6 months, or being diagnosed of 1 or more STI, or having had post-exposure prophylaxis, or people using drugs for sex. Is that what we call the chemical sex, no? But also in these guidelines, it's stated that other people could get benefit from the PrEP, like serodiscordant partners of an HIV person not on treatment or not yet with viral loads undetectable, and also for sex workers or for people who use drugs and share syringes, and also for some people with more vulnerable because of social factors. So in Spain, the recommendations are very, very clear and agreed among all the experts. And what's the current situation in Spain? Well, we know that there are people who are already taking PrEP. It's because they buy the PrEP. Michael is going to explain much more about this because we have also data and it's very interesting. But we know that people buy through the websites, the generic Truvada. The most used is the Tembir. It's what we call the informal PrEP, but there is usually any kind of medical control, so this represents some risk. But as I said before, Michael is going to talk more deeply about that. Right now, there are 2 implementation studies planned in Spain. One is sponsored by the Ministry of Health. It's planned the sample is planned to be 400 MSM and transgender women with a follow-up of 52 weeks, 1 year with 48 weeks of treatment and then a follow-up. So it's will be only for 1 year. And the schedule of visits is every 12 weeks. The first week would be 4 weeks after starting the treatment with an STI screening. And the regime, it's Truvada daily. But as I said before, this is not yet implemented and probably would be implemented only in 2 or 3 cities. It's not yet decided. Another implementation study, which is being planned in our country, this is in Catalonia, and it's through a grant for research called the PERIS grants, and it's planned to implement the project among 35 MSM and transgender women. We know that it's a few people, then it's not probably not a very powerful implementation study, but this is mainly because of the economic constraints of the grant. Now we are trying to increase this number, or at least to focus on those people who could be at very, very high risk, like transgender women, the sex workers, etc. The follow-up is it's longer. It's 144 weeks, so it's with 2 years on treatment, and the visit schedule is the same, or it's the same than the one who's going to implement the ministry, and also the regime is the Truvada daily. This is already approved. We already have the budget for that, and it just we have to define whether we can increase the sample size. Another option is the Discover study. The Discover study, it's a phase 3 randomized double-blind study to evaluate the safety and efficacy of Truvada versus TAF. What they want to compare and to show is that the TAF with Emtricitabine is the same that the Truvada for PrEP. We already know this because we have been using in a HIV patient for more than 1 year in our country, but it's not been used for PrEP. So the objective is to show that also for PrEP can work. At the end, the sample size is 5,000 people, the MSM and transgender women, And the criteria, as you can see, is that these people have condomless anal sex with at least 2 male partners in the past 12 weeks, or they have had syphilis in the past 24 weeks, or they have had a rectal STI, rectal gonorrhea, or chlamydia in the past 24 weeks. And of course, they have an adequate renal function and also an adequate liver and hematologic function. Otherwise, it's an exclusion criteria. The sponsor is Gilead Sciences. And in this study, the recruitment is already completed. And we have to bear in mind that it's a research study. So we cannot say to the participants that, okay, so you get the PrEP, you are, they have to be aware that this is a research study, and then they can be allocated to Truvada or TAF. And of course, there is a very close follow-up, and the rationale behind that is going to work also, but we have to show that. And another option, well, if you go to another European country, you could get PrEP if you go to Norway or you go to France. And we should add to this map also Scotland. And very, very recently, we know that also in Belgium, it's going to be it's already available within the national health system. And it's also in Luxembourg, but not in an official way, but also they provide PrEP within the National Health Service. So, whereas before, many young people had to leave the country to look for a job in other countries because of the economic crisis in Spain. So maybe some of us, we should, or some of them will have to go to other countries to get the PrEP. No? And looking at the challenges, well, the first, of course, is making PrEP available for all who can benefit from it. For that, we have to address this skepticism from clinicians, the community, even payers and general population. I should say that the skepticism among clinicians, it used to be more important 2 or 3 years ago, but now I would say that more and more clinicians are aware and they are in favor of PrEP. 2 weeks ago, I was in a conference. I was giving a talk in a conference. I was talking about PrEP, and I asked at the beginning. So there were about maybe 60 clinicians, doctors, and most working on HIV, of course. And I asked, do you think we should just implement PrEP right now? And only a few, maybe 2 or 3, said, well, I have doubts. But the rest of them said, yes, definitely yes. Michael will talk more about the gay community, but also it's this skepticism. It's I would say residual among the gay community right now, and also we have to. But that doesn't mean that we don't have to try to increase the awareness among health professionals, because probably, as I said before, the talk I gave to this group of doctors was not a representative sample of all the health professionals, because they were working, as I said, on HIV and the HIV field. And definitely we have we cannot talk anymore of prevention without talk about PrEP. So we have to adapt our messages about PrEP. What challenges I think we have is to define appropriate models of care and access points. Michael will talk also about this, and we know that a person who looks for PrEP is not a patient, and probably he wouldn't feel very comfortable in a hospital, and for sure he will prefer other kind of places for getting the PrEP. And Michael have very interesting data on that. No? And also we had to talk about the restriction of the medication, the Truvada, because Truvada is a drug for hospital use only, which it makes sense if you use it for patients, but not when you have to use PrEP for the Truvada for persons who are not who only are for PrEP. No? This means that we should, we not do it, but the ministry should change the law allowing this medication to be provided in other health or community centers apart from the hospitals, but well, this is a roadblock or could be a roadblock right now. Another challenge is to find other ways of PrEP, other new formulas like the long-acting drugs. There is a study, ongoing study to assess the cabotegravir. This could be injected probably every 2 months. We're still expecting for the results. And this a key issue to reduce the cost of drugs for PrEP is the price of the trial, the drugs for PrEP. It's crucial for the cost effectivity of the PrEP. We know that this is also something which could be not at our level, but at higher levels, so ministry levels should be also worked. And last is that, of course, we have to monitor and evaluate the PrEP implementation, but I don't think that means that we need more implementation studies. I wonder, do we really need more implementation studies? We know that the effectiveness of PrEP, so the time for debate, it's on the effectiveness, it's over. My last question would be, what are we waiting for? We already have studies in other European countries, implementation studies, and now I think that it's time for action. And that's all from my side. I would like to give Michael the floor. Thank you.
Yes, good morning and good afternoon, and I want to thank Carla for the invitation to present our activities here in Spain, and I would like to start and focus on the answers that we are giving from the community, where we have been working for a long time, for a long number of years. But I would like to start probably about 2 years ago, after the presentation of the results of the HIVACAT and the PROUD study that would be in the CROI of 2015. And so if we go back to that year, during the Spanish AIDS Congress in May 2015, we organized a parallel session on PrEP, and we included, there was a very lively discussion. We included a video of a person who was taking Truvada at that moment, so like explaining from a first person the situation. The second step was to create awareness in the community. So I've been doing a lot of talks in community settings. And as I mentioned before, there was some skepticism in some of the gay organizations and also in some of the HIV organizations. So we decided to create a platform, which we call Platform of Case Against HIV. That was in November 2015, and it's created by the most important HIV and gay organizations in Spain. Just after that, after the creation, which got a lot of attention in the press, we organized a protest on World AIDS Day, the 1st of December, in front of the government building, which had a lot of attention also, because it's one of the first times there was something new to be presented, and we asked for PrEP implementation right away. During 2016, and as a result of the protest, there were some work groups formed, and just work on the implementation of PrEP. It was done on a Catalan level, but also on the Spanish level. As Pep mentioned, as community, we were also involved in editing the guidelines on PrEP, which was presented in July 2016. And the other thing which was so important was that in the summer of 2016, we had a great demonstration project established, and it was at the highest level of Gilead, who was asked to donate drugs, and should be done in Madrid, in the biggest STI clinic, and in Badalona Checkpoint. And just before the final decision was made, the Spanish Ministry of Health aborted the project and threatened that it should be cancelled because they didn't allow that. And they wanted to do their own implementation project, which is still in an unclear situation, as Pep presented previously. Moreover, during the year, we have been present at Pride. We have here you can see the picture where we say stop HIV and we want PrEP now. Very clear message to the community and with participation of the community. We were also present at big festivals like the Circuit Festival. Here you see a photo call where we ask people to join us and post their pictures on Instagram, Facebook, and all the other social media. And by the end of 2016, again, World AIDS Day, we presented this campaign of Case Against HIV, where we accused the Spanish Health Ministry that every day they delay the access to PrEP. In Spain, there are 10 new persons diagnosed with HIV, and this is very clear numbers, and this is really the situation, as we know that Spain has the highest rate of infections of Europe. On the other side, as Pep mentioned, we know that people are taking PrEP already. And we know that from one side of a study which was presented and worked on together by the ECDC with Hornet. This was done in April 2015, and more than 8,000 persons responded to the questionnaire. And globally, of all these people of all countries, the response to the question, are you currently taking PrEP, was 10% said yes. So this, we thought at that time that it was quite high, but we have to bear in mind that it's a global number. More recently, there was another study done in Europe, which is called the Flash PrEP study. And as you can see that, and these are the conclusions, you can see that a significant number of people are taking informal PrEP, but not always doing all the adequate checkups which are required for taking PrEP. More specifically in the Flash PrEP study for Spain, here you can see there were some questions about asking people about the awareness of PrEP. You can see that 75% said yes, they were aware, but it's not enough to know that they are aware of PrEP. We wanted also to know what if their knowledge about PrEP is correct. So there were some questions asked, and the result is that 81% has a correct knowledge of PrEP, which is higher than the average in Europe, which was very encouraging. On the other side, about acceptability, we can see on one side, if you see, I hope you can follow my cursor here, you can see that around 80% would definitely not, or probably not, use PrEP. So the other important message is that probably not everybody wants to take PrEP. But on the other hand, you can see that 26% yes, probably I would be interested in using PrEP, and 31% said yes, definitely interested in using PrEP. And so on the other side was the intention to use if and when PrEP is becoming available officially, and then you see the same figures. 31% would say definitely yes, 29 would say probably yes. And with the question, the intention to use PrEP before it becomes officially available, so we're talking about informal PrEP, and you see the numbers are lower, but still 7% would say definitely yes, and even 11% would consider using PrEP. And with the question, if they are using already PrEP, then it said 2%, in this case 6 cases, said yes, interested in taking PrEP. So the knowledge is there about taking PrEP. People want to take PrEP, and also there is the website I Want PrEP Now, where people know and learn how to buy PrEP through BADA online, generic drugs. And in this year, there was a Spanish website created. It's called quieroprepya.eu. So if you want to check out that, it's important. And it not only explains, because we have some additional difficulties in getting PrEP to Spain, as the customs will or are able to stop at the frontier the medication, or there may be other difficulties. So the website is not only showing how to buy it, but it's also collecting case reports about the experience of people buying drugs online. And that brings me to the final point, which is the future plans of Badalona Checkpoint and the organizations, which is after Badalona Checkpoint. We hired a place next door, which is called Badalona PrEP Point. And what we wanted to do, and it's foreseen to open in September of this year, of course, we will go on with give information on PrEP. It will be the place for clinical trials like the Discover study or the other implementation studies. And the other thing which is important is to give people guidance and start a harm reduction program for people who buy drugs on their own. So we have a group of pharmacists who collect data and talk about drug interactions and checking renal functions. We check STIs, including HIV, of course. So this will be an important program starting in the PrEP point. And in the future, when and if PrEP will be available in Spain, as Pep Coll mentioned before, it's not probably to be delivered in the HIV units in the hospital. So we have to look for alternative centers, and we think that a user-friendly place like a community center where people are already used to go there for HIV and STI testing, it will be the place to deliver PrEP and make sure that there will be a great uptake. As you know, we've seen that from the experience from US and also in France. When PrEP is available, that doesn't mean that there's right away an uptake of people taking drugs. So I think a community center can make the difference. And finally, of course, we will go on with community research as we've been doing till now. So with that, I will stop, and I guess we will having questions. So I would say thank you.
Thank you. Thank you. And Michael, very interesting presentation. And yeah, please, those who are here, if you can use the chat window for any comment or question you may have. For the time being, I have a few. Definitely, first of all, the realization that concerning PrEP, access hasn't been automatically easier in higher income countries. Definitely, the US is the country where PrEP has progressed, has been scaled up really significantly at this up to now. No other country perhaps France. I'm not completely aware of the level to which PrEP has been scaled up in France, but definitely it's the other country, higher income country, that is already providing PrEP. I mean, without restrictions, as far as I know. But in other countries, I understand people are still struggling, and particularly in Europe, we have many countries that haven't, where the situation is very much like what you are describing for Spain, and it's very interesting because, in a way, it is possible that in some countries, maybe in Africa, access to PrEP will probably be much easier because of a difference in access to generics, no? To generic drugs. So I mean, that's kind of a paradox in terms of health systems, and I mean, eventually later, if you can provide a comment on that, it would be interesting. But I would ask first, what opportunities are provided by the country, and what opportunities are provided by the European Union in this case? Is there any option to be considered from the European Union point of view, or really this has to be dealt with at the country level?
Well, it has to be on the country level. That's the short answer. On a European level, there is the approval of, in this case, Truvada for prevention. It's for Truvada. It's probably not for generic drugs, which is now one of the complications. Then the second step will be a recommendation from the EU for the member states to implement the new drug. But then every member state has a period of time, it's about 6 months, to look for the way how to finance within their social security system the implementation of the drug. Now, in the practice, this 6 months means that it's more than 6 months. We have, I mean, it was approved in August last year, and the recommendation from the EU was from September, so we've already passed 6 months.
Okay. I think there's a question from Ricardo Baruch. He thanks for the presentation and asks whether it's possible to access the generic drug in Spain, or would people and the government have to buy the original Truvada? No? So yeah, that's. I mean, the question then is, which is, I mean, a series of related questions. Access to the generic drug locally or via the internet, so, and also what's the cost of the? I mean, if the original Truvada is available in pharmacies. Apparently, from what you said, it's a drug restricted to hospitals, so probably it has to be, I mean, it can't be bought purchased in a drugstore. And that is important because apparently some drugs that can be purchased in a drugstore that here are quite expensive. I have no, in Peru, I know that in Spain, probably for, due to specific deals, can be purchased at a quite reduced price in drugstores in Spain. You know? So probably things that here may cost approximately 40 or 50 euros can be bought at 10 euros in Spain. So I am just wondering the status of access to the drug, I mean, generic versus the original, and the price.
Yeah, no, you cannot buy neither generic drugs in Spain, neither the Truvada, because the hospital, you cannot go to a pharmacy and to they say, oh, okay, I want Truvada, neither to a pharmacy of the hospital. So the only way is it's through these webs where you can buy the generics. And that's, but as mentioned Michael before, with the constraint of the customs, and it's not legal to, well, it's not legal. You import drugs, a drug like this, then usually at the mail office they do a random control. So sometimes you arrives to your place, but sometimes it's stopped there, as Michael said, and then you have to do through what we call agente de aduanas. Then you have to say that this is for your use, and which delays the delivery of the drug. But the short answer is that no, in Spain you cannot get neither Truvada neither generic.
Let me just, the only country in the EU, if it's still part of the EU, is the United Kingdom. That's the only place where it's officially allowed to buy generic drugs if you can't get it in the normal way. So it's a protection for the consumer, let's say. In all the other countries in the EU, it's not permitted to buy online prescription drugs. Now, the other thing is that what are we allowed to do within the EU? That means that I can buy drugs in one part of the EU and travel with that to my home country, and that will allows you, and that's a little bit different, but in general it allows you to take with you 3 months of supply. So if you're not taking PrEP on a daily basis, but on an event basis, that probably it will gives you drugs for more than 3 months. I know on the other hand, for example, in the Netherlands, that the customs, what they are looking for is they allow you to bring with you maximum of 300 pills, which means like 10 bottles of Truvada. So you see, there's some slightly differences between the different countries. So one possibility would be to buy it and that they send it to your home. The other possibility is to buy it and let it send to somebody in the UK, and then you travel with a cheap ticket, let's say, to the UK and bring it to you at home. So
now, just to complete this point, what is expected to happen after the patent of I think tenofovir, right? Or expires next year.
Well, actually, it should expire in July of this year.
Okay.
But we know that Gilead asked for prorogation of an extension of the period of the patent, and so it will probably 1 year more. If not, yes. So there are. It's still a battle because the generic drug manufacturers are waiting to come into the market. And when that happens, then probably the price will drop 40%.
Okay. Well, interesting.
So we are waiting now what one judge at European level is saying about the demand of Gilead versus the generic manufacturers.
Mm-hmm. Okay. There's another question by Percy, and he says something. Significant concern we have in Spain is that many people working in with MSM regret the lack of protocols concerning PrEP implementation, including psychosocial interventions focused on avoiding sort of collateral damage, secondary effects that would generate the implementation of PrEP, for example, stigma associated to PrEP among MSM, and then the issue of bias and prejudice among health providers concerning who to prescribe PrEP to. Protocols should be very clear, but or are apparently very clear, but in practice, what is observed is that prescription might depend on prejudice and bias. No? So one, apparently this is a factor, I'm translating what Percy wrote, one factor that being considered is to invite MSM to know more, to learn more about PrEP, about benefits, and the fact that I mean, this is not actually psychosocial intervention. No, it's something that they need to know anyway. It's okay. So I don't know what would you say about this?
Well, there are different aspects. So let me go step by step, and Pep can complement. I think on one side, as I showed, we have been working for many years to create awareness and increase knowledge within the community. I think you've seen some examples of that. You also have seen in the Flash PrEP study that the knowledge is quite high. It's even higher than the average on European level. The other thing is that you can see is that there will be always a group of people who do not want to access PrEP, which is perfectly fine. I mean, everybody knows what he wants or not wants, or needs or not needs. So that's completely fine. It's what we know is that there's a high incidence in the community. We know also that people are aware of that and people want to protect them. That doesn't mean that they don't use condoms anymore. That is a choice of individual choice, but some people will use PrEP and will use condoms. So I think that's very clear. On the other side, as for protocols, I think which is the leading authority in Spain is the recommendations of the guidelines of HESN. And HESN was one of the first European guidelines edited before any other country. So I think how to use and to control the harm of eventual adverse effects or whatever, I think the protocol is very clearly established. And as for how you say, as for the clinicians which may have some opinion about users, I think that's the thing we have to look now. I think it's not the traditional way of getting the drugs to people. We have to look for alternative ways like STI clinics, community centers, and we have overcome that barrier in the past 10 years. So people know perfectly where they have to go. Pep, do you want to add something?
Well, regarding the stigma, I don't have the feeling that the people can, this can be a barrier for people. Not nowadays, but maybe before, when we remember when we were talking about the Truvada horse, and the people taking Truvada was could be seen as very the bad guys, no? But I don't think this is anymore like this. And regarding from the health professionals, especially I said before in that talk I gave, everybody was in favor, but probably it's not a representative sample of the whole health professional. We know that from the health sector also many health professionals could also stigmatize those who are going or who want to take PrEP. So, and regarding the side effects, which could have, well, there is a concern for the STIs. Many people say, "Oh, the STIs are going to go up, and this is going to be a real disaster. This is going to be the end of the world." Well, this increase the STIs, it's already happening right now with no PrEP. And there is a very interesting presentation in the last CROI, and it's a mathematical modeling. The conclusion, or one of the conclusions, was that if we implement the screening programs for STI on a quarterly basis, then the incidence of STIs would go down. And even if this screening was performed every 6 months, so we want to control this STI epidemic. There are means for that, and the answer is not okay. So don't take PrEP, because then you are going to have more STIs.
Yeah, that's very interesting. Yeah, that's what I wanted to ask. In fact, to an extent, there was consciousness among professionals and among the community about the STI epidemic. And do you have any figures, any numbers about syphilis, gonorrhea, chlamydia that you could share?
There are quite a lot of information, but it's, there is no an agreement on. The conclusion is that we cannot say that the PrEP is the cause of this STI increase. This is also one of the conclusions of this presentation in the last story. But yeah, we have data, and in some studies, for instance, in the PROUD study, there was a slight increase of STIs among the people in Truvada, but which was not statistically significant. The difference with the people not taking Truvada. In other demonstration studies or in the real world, in some settings, they have seen an increase of STIs, yes, of course, but there is no, we cannot say, okay, there are more STIs because people are taking PrEP. It's not like this.
Carlos, may I add something? We have data in the last 2 years in the checkpoint. We have been checking for STIs, and so without PrEP, I can tell you that 1 out of every 5 clients coming to Barcelona checkpoint do have any kind of STI. So that's what we know. That's
sorry, not any kind. There's only chlamydia and gonococcus. No syphilis included.
No,
with syphilis could be more, even more.
Yeah, it would be more. And if we look especially on chlamydia and gonorrhea at the rectal side, we can see that it's 7.2 and 7.4%. So these are very high numbers. And the other worrying thing about rectal infections that we know is that around 80% of the rectal infections are asymptomatic. So people don't have any complaints, and just the opportunistic way of testing helped us to detect these infections. So the problem is not that PrEP will increase STIs. The problem is that we don't have active screening programs, especially in MSM. So what we think is that the implementation of PrEP will give us the opportunity to detect and treat and cure these STIs.
That's a very important point, and yeah, exactly. When I asked about STIs, it wasn't necessarily asking about them in relation to PrEP. I was more interested in the background prevalence or incidence of STIs, because that tends to be the problem in many places. And I agree with what Pep mentioned about the CROI presentation concerning the opportunities that PrEP follow-up offers to screen on a regular basis for STIs and treat accordingly. That's something that would actually become an important value added to participation in a PrEP program, because definitely without PrEP, STIs are very, very high, which means as well that condoms are not used regularly. Of course, we know condoms protect slightly less against other STIs, but still, if condoms are used, prevalences would be low, much lower. And the other point that is of concern is that clearly the prevalence of asymptomatic rectal chlamydia and gonorrhea is high. The proportion of asymptomatic rectal infections for these two diseases. So what we need, unfortunately, when there are no symptoms, are these NAAT testing, PCR for chlamydia and gonorrhea, and this kind of test is not widely available. It's probably done in many parts of Europe, but in many other parts of the world, it's just not available in public services. So definitely, it's something that needs to be implemented regardless of PrEP, because asymptomatic infections are very common. Anyway, there's one more question from Juan Vicente, asking about whether or not TDF, tenofovir plus lamivudine 3TC is being considered for use in Spain, if it has been discussed or not.
Well, that's a good question. In fact, we were also wondering whether this could work. For that, well, the answer is to know that we should implement a clinical trial in this case, comparing with the Truada. It should work, but we don't know. And probably also this kind of a study would require a very high sample number of participants in order to be able to show that there is also the same efficacy, no? Yeah, it's in terms of economic terms would be a very good option, of course, but it has to be proved it works.
I think WHO is working very much on this combination, and they have trials going on in many parts of the world. As for Europe, if you're using tenofovir within this combination, you will still fit up with the same problem. You have the problem of the patent of tenofovir. It's included. So until the patent isn't over, it wouldn't be a real option in the sense of price.
Yeah, let me say, however, that definitely I understand that the two molecules of lamivudine and emtricitabine are very similar, and I understand there's no reason to think that the way they operate is significantly different. So, I mean, there may be differences in terms of, what is called forgiveness. No? I mean, how many pills can somebody skip and still have active drug in their blood? No, so it's not completely clear. But in general, I mean, if there's good adherence, probably there's no reason to consider that there will be important differences. So I understand that WHO is sort of thinking in those lines. Anyway, it's something for them to express, so we will probably hear about something about this relatively soon. Anyway, it's already 10, and I think it's been a very interesting dialogue because definitely by looking at country-specific cases in both higher income countries and lower middle income countries, we can sort of come to understand why the use of this technology that is, I mean, has a role in combination HIV prevention is still so low after so many years of demonstrating its efficacy, and how we can do to actually provide it the place, have it play the role it might play. Anyway, really, I thank you very much, you both, Pep and Michael, and this is going to be uploaded soon for all of us to listen to. So we'll let you know. Again, and with everybody else, I mean, thanks for being here, and we'll be in touch about future webinars.
Okay, thank you very much.
Thank you.
Thank you both. Bye-bye.
Bye.
Bye.